All right, welcome everyone. Happy spring. This is the quarterly Primary Care Council meeting. Slides going through. Before we officially start, we do want to pause on behalf of my colleagues here at the Healthcare Authority. We humbly acknowledge that we are on unceded ancestral lands of the original peoples of the Pueblo, Apache, and Dene, past, present, and future. And if you all joined just now, you missed our conversation about open toe shoes. I'm really glad and so happy for this warm weather and springtime and the leaves turning green. New Mexico is such a special, beautiful place. I love it here. I feel very at home here. And I want to pay my respects and gratitude to this land and the people here and the communities that contribute to New Mexico. All right. And this work of the PCC does fall under the Healthcare Authority. And at the Healthcare Authority, we're working hard to help New Mexicans attain their highest level of health. And we're doing that through providing whole person, cost-effective, accessible, and high-quality healthcare and safety net services. And this work aligns so well with that mission here at the Healthcare Authority. And the Primary Care Council has a vision to revolutionize primary care into interprofessional, sustainable teams, delivering high quality, accessible, equitable healthcare across New Mexico. And we're doing that with partners, patients, families, and communities. And we have this vision that's coming up. 2026 is right around the corner, but we would love to see same-day access to high-quality, equitable healthcare for all persons, families, and communities. We're going to talk about these things a bit today. We also have goals to help us achieve our mission and vision, and we have work groups that match these goals. And like I said, we'll take some time today to talk through our mission, vision, and goals. All right, welcome. I'm Elisa Reed. I'm the Strategic Planning Director here in the Office of the Secretary, and it's been my privilege to work with this group of dedicated providers and community members. So welcome today to this meeting. We will have some opening remarks today from Jen Phillips, our PCC chair, followed by some housekeeping items. We're going to talk about reinvigorating the PCC. I know you all are kind of chomping at the bit to get going on more work and see more work happen in New Mexico. So we'll talk about that today. We'll take a quick break with a poll about EHRs. We'll talk about our PCC bylaws. We really want to have a strong bylaw document to help the Healthcare Authority really achieve what the PCC wants to do over the next few years. We'll talk about the roadmap for payment reforms in primary care. We'll have Keenan, a former PCC member and current Healthcare Authority employee, talk about the preferred drug list RFP. And then we'll talk through some next steps and closing comments. All right. And for those of you who have joined today, today's meeting is intended for the core members of the PCC. If you're unsure if you're a core member of the PCC or not, put that in the chat. We'll let you know. But basically, if you're part of our work groups, if you're part of our membership, voting or non-voting members, then you are part of the Primary Care Council. If you're here as a member of the public, then I wouldn't consider that a part of the PCC, but we do have ways to engage with everyone. So for PCC members, please raise your hand, jump in. Really, this meeting's for you, so we want to hear from you. For those that are here for public comment, we would respectfully request that you use the chat space in the Zoom to ask questions and make comments. That way we can really focus on those members that are here today for this meeting. Please take breaks if you need them. This is a 3-hour meeting. We will have a 5-minute break in the middle. But if you need to get up, get coffee, get a snack, please do that. All right, and I will turn it over to Jen to give some opening remarks.
Thanks, Elisa, and thanks everyone for being here. I'm Jen Phillips. I'm a family doctor, and I've been the chair of the Primary Care Council really since its inception, and very happy to do that. I do think that we have an announcement about maybe some changes around that today. Is that right, Elisa? Okay. So I'm excited for that. It's been about 4 years, actually, I think, since the council started, and I've been really privileged and honored to be able to help lead the group. I want to thank everyone who's been working on the Primary Care Council, the connection with the state and this work around increasing investment in primary care, I think is still really essential. I'm kind of excited to see us get back a little bit to our roots with Elisa here and kind of her warm handoff, very slow warm handoff to a new leader administratively in the state office. I want to encourage the state and the healthcare authority to really use the Primary Care Council for feedback and work in this space. I think we've made great strides in payment reform, but I think there's some more work to do there as far as making this really, really easy for the practices and not something that's a burden. You know, that's really been a key theme. So getting back to that. I also think the real focus should stay on increasing the investment and spending that happens in the primary care space. There are multiple groups that I think can be aligned to that cause. I also think as state priorities, we need to focus on the healthcare workforce and the issues that are really hitting our communities, like substance use disorder. And sadly, things as far as funding at the federal level are not always flowing in our favor. And there's going to be changes, I think, that are somewhat discouraging and frustrating to us who've been working kind of the opposite direction. And I know that we've seen the Making Care Primary rolled back, and you know, there's concerns about some of the other value-based care work and initiatives that have been really going full force for at least the last 4 years. We're seeing in our institutions a decreased funding for education and research, which is also very scary and disappointing. And I think the next several years will involve lots of strategy, alignment, and efficiency, to use a word that is not at all favored in my mind at this moment. And that will not be easy. So I encourage us to continue to step up, stay present, moment by moment. And I do believe that there is always opportunity and challenges. So thank you so much for having me. And yeah, let's get started.
And I just want to pause for a moment and tell you how appreciative I am, the state is, and this group is for your leadership over the last several years. You've really been such an optimist in this work, a realist when needed, and willing to criticize when that's needed too. And I just so have enjoyed working with you in this capacity as the chair. And you know, I want to just have everyone take a moment and give some applause to Jen for the hard work that she's done. So thank you. We'll have our announcements here right away. So we did get a couple of nominations for chairperson, and I'm really excited to announce that Val, who's here, is our next chairperson. Val's been also with the PCC since its inception, is such a great advocate for this work. So Val, I'll just invite you to say hello. I know you're going to get some comments in as well.
Thank you. Thanks, Lisa. Yeah, so for anyone that doesn't know me, I'm Val Wengler, family doc out at Gallup Community Health. And, first, Jen, just thank you so much for everything they've done over these last 4 years. It's really been amazing to see it all come together. So really appreciate everything that you've put in. It's big shoes to fill, but I'll try. And yeah, I mean, I just totally echo everything that you said. It's again been exciting to see what the PCC's done over the last few years, particularly in payment reform, workforce. But with the recent changes, there are going to be some real challenges and a lot of really important and hard work ahead. So I am honored to be a part of it. Totally agree that we want the state to come to the PCC, rely on the PCC, allow us to continue to help guide and lead that work. So yeah, excited to jump in. Appreciate the trust that you all are placing in me by letting me serve as the chairperson.
Thanks, Val. So looking forward to having you at the helm and working with you more. I know I've worked together on many things, so looking forward to continue that work. And so excited. It's been over a year looking for the right person to take my place as manager of this work. And we found someone that I'm just so excited about. I've had a chance to talk to Tristan several times. She comes with such great experience with committees of this type, councils of this type. And Tristan, I'll let you introduce yourself and kind of give a little of your background.
Sure. Yeah. Hi, everyone. Nice to meet you all. Can you hear me okay? I'm trying out some wireless headset today, so glad you can hear me. Yeah, so I'm Tristan Maroney. Let's see a little bit about me. I was born in Santa Fe, Indian Health Services, grew up there, went to UNM for undergrad, stayed for med school, left after that, thought I would never be back, but came back. Short story, left medicine and somehow joined the state government doing some public health prevention work at the Child Welfare Department. I worked on I got the project, the CARA program going, if you know about it, the Comprehensive Addiction Recovery Act. And also, I guess before that, sorry, I should have said, I worked on the Children's Trust Fund and CJAG and some other councils prior to that, and then moved over to CARA when we were getting ready to launch that. So really enjoyed that. Went to Department of Health for a bit, and then I was just at Early Childhood Department working on a preschool development grant for the last year and a half. And happy to be here. It feels like a right fit for me and my background. And it's definitely the kind of work I like to do, to build things and do some macro level stuff. So yeah, I'm looking forward to working on this council and the payment reform that you all brought to fruition, and see what other cool stuff we can do in the state. I'm here for the long haul. I've got some young nephews and family, so I'll be here, for quite some time, and I'm looking forward to it.
Tristan, I'm so excited that you're here, and I feel like, yes, you're the right fit. And it took us a long time to get here, but we're here. So looking forward to the work that we will begin again here shortly. All right, just a reminder on our strategic planning cycle that matches up with what happens here at the state. We're here at our PCC quarterly meeting right now. We are going to be establishing our PCC bylaws in May. We'll talk about that today. Now's the time to start thinking about potential new initiatives, because even though the session just ended, We're right back to work thinking about how to improve, what we do in New Mexico so that we can prep for the next legislative session or the one following. All right. And with that, as just some quick legislative session wrap-up items, some session highlights for us, the Medicaid program. We did receive funding for implementation of new services for individuals exiting incarceration, which is fantastic, for pregnant people with high-risk pregnancies, people experiencing homelessness who need medical respite. We also will talk here in a moment a little bit more about the Behavioral Health Reform Investment Act. That was Senate Bill 3, for those of you who saw that in the news quite a bit. And Rural Healthcare Delivery Fund, which is the fund we've received 80 million the first year, 46 the next year. That's to really help expand and increase the number of services, including primary care in the state. Alex Lewis here, she runs that program now. We did get 26 million. I think 26 is the right number, Alex. Now I'm questioning myself. For another round of applications. So super excited. Some of the PCC members are actually recipients of that fund. We also had several bills supporting healthcare costs this year. And, just to reiterate, I know we talked about this last time, but there is a lot going on in the federal environment. And, the cabinet secretary here, Carrie Armijo, Governor Lincoln Grisham, we're all very dedicated to ensuring that New Mexico and Medicaid in New Mexico is safeguarded and that we continue those services. So, we're still working through news as it comes in, but we are very much paying attention and dedicated to making sure that people continue to get the care that they need. All right, Senate Bill 3. Jackie is here as well to help answer questions on Senate Bill 3. But really, this is the package that the legislature passed around behavioral health reform in the state. And so there's a lot of work that's going to happen through our Behavioral Health Services Division around behavioral health. But I wanted to point in particular that in the bill, it does ask us to set up medication-assisted treatment in primary care settings. And so there is a huge opportunity here for Primary Care Council to really help guide the state in that particular work. Not to mention, the other work that's happening with this bill, because as you all know, we consider behavioral health part of primary care. But we'll have an opportunity today to talk a little bit more about that in potentially a breakout room. But I did want to flag that for you all. And I won't go through all of these bills. I put some in the deck that you'll get a copy of. There's links here in the deck that you can read more about each of these bills. And this is not a comprehensive list of bills that passed that deal with healthcare, but I thought these might be ones that you would be interested in. In particular, doula credentialing. We are going to be able to credential doulas to help us in New Mexico pay for the work that doulas do. And so that's really exciting for our state. And then the Medicaid Trust Fund was set up. So this is really another way that we can ensure that Medicaid continues regardless of what's happening in external environments. So that was established by the legislature as well this year. All right. I feel like I'm almost done talking, so I don't want to just talk at you all today, but feel free to reach out if you have questions, concerns about any of the legislation that happened. All right. So for today, for the next about 90 minutes, I really want us to take some time to pause, to really think about, what are we trying to accomplish with the PCC? I feel like I'm still sort of dusting cobwebs a bit. Um, Tristan's also new. I think this is a great chance for her to hear from you all about what your hopes are for the PCC, kind of where we're at now. And then I'd like to also talk about the timing for making revisions within our mission, vision, and goal, the purpose of sort of that revision, and then like revitalizing our goal areas and our work groups. All right. Promise I'm almost done talking. This is just to help us dust off cobwebs before we dive into this conversation. In House Bill 67, that established this council, we do have some duties. Some of these, I'm not going to read them all, but some of these we've accomplished. Some we have not yet. I think we've made some great strides in some areas. I think primary care investment, to Jen's point, is going to continue to be something we want to work towards. We also have this duty to recommend policy and regulations. So thinking about where we're going in the next few years politically, both at the state and federal level, that's something we're thinking about too. Okay. And this is our PCC 5-year strategic plan. Tristan, if you could pop it in the chat now, this would be a great tool, resource it for you all as we have conversations today. If you just want to pop it up, it's a big document, but it's pretty easy to navigate if you kind of want to look at a goal area and see what we were talking about back in 23 or what we wanted to accomplish. We really did some pretty comprehensive thinking about what was possible in New Mexico. And I think many of the items in there still ring true, but there might be some things missing. There might be some things that are different or new now that we didn't know about 2 years ago. So I'm going to cross my fingers that this tool works today. Let's try the Zoom whiteboard. If it doesn't work, we'll do something else. Let's see, whiteboard. Bear with me. Technology is glitching. There we go. Can you all see the whiteboard? Did it all pop up on the Zoom meeting for you? Yay! Okay, I've never done this before. All right, for those of you who are watching the Zoom, you can zoom in, zoom out, using your mouse. There are sticky notes here to add. I've put a few blank ones in here. But what I'd really like to know, and please like shout out as well, and we'll add sticky notes for you all. What's happening in your work, in your communities now with primary care? What's happening with your families? Families you know. Are they experiencing a lot of the same things that they were when we started this PCC in 2021? What's better? What's worse? What's different? Or, what's your outlook for the future? Are you feeling positive about primary care in New Mexico? In the next 5 years, are you feeling worried? So I added a few here. So for me, the next 18 months is pretty critical to really wrap up some work, get work going. We only have about 18 months left in Governor Lujan Grisham's administration, and then we'll have a new administration who may come with new ideas and thoughts about healthcare in the state. there was a very big focus on primary care and healthcare workforce in the legislative session, which was really exciting to see. Also primary care payment reforms. Okay, I'm gonna stop talking. I'm gonna let you all just jump in, add sticky notes. Some Jeopardy music here. A lot of worry. That's pretty common sentiment at this moment. Anybody willing to speak up and talk about what they put in the chat? Be interested in like that. I'm gonna call out the things that I'm seeing here. Some themes other than just general worry. I'm seeing that there's continued access issues. Not only with care, but it looks like with social services, mostly. I'm concerned about malpractice. I'm concerned about making sure value-based care is engaging clinicians. And some excitement about peer support. Trust from experts and educating more. Anybody want to? I don't want to call on people, but I will if no one wants to speak. I'm call on Jessica. I know you have a great perspective on what's going on with human resources for folks. Did you have anything in particular that you're concerned about or excited about?
Yeah, sure. I'm happy to talk about that. I'm Jessica Osenbruga. I'm the Senior Director of Community Health and Engagement at Roadrunner Food Bank of New Mexico. And in this work, we are interacting with many community members at food distributions and community events who are telling us that they don't have any connection or access to healthcare at all. And they are also, they're food insecure, and they oftentimes are having other health-related social needs or socioeconomic factors that are occurring for them. So sometimes Roadrunner, as a community-based organization, and its partners are in the place to help folks get connected to both healthcare and to other programs in the community. And I'm concerned that with these very big looming cuts at the federal level to both Medicaid and SNAP, that things will snowball and be even greater challenges. Roadrunner Food Bank is being approached by, I can't even tell you, it's been an avalanche of requests from government bureaus, from healthcare, from other community-based organizations, and everybody's very anticipatory of the very large growing needs for people to connect community-based programs, resources, healthcare access. That is, I spend 10 hours a day receiving these requests and these concerns from everybody. So, but somebody said it. So I want to end this on a silver lining note. Somebody said it very well, that in all of these challenges, I find incredible opportunity so long as we deploy creative, dynamic, and catalytic thinking.
I always appreciate your perspective with community members.
Thanks.
I'm gonna try to put somebody else. John, I know you're off camera and muted, and I know you have busy days, but John, either Andon Zola or John Helm, we have two Johns here. I should probably clarify, either of you wanna talk about what you're seeing?
How am I supposed to follow that up, Jessica? That was amazing, inspirational words. Okay, my thing too, I really want us to all think about our bills and how to lower those costs for small providers, because I think that's where the financial opportunity with the primary care council lies, in that anything that you see on your daily passing your desk that you're like, I wish this was not as expensive, I wish I could get some help with this. I think that's one of the things that I'm going to try to think about and try to help through. I've been trying to think through an idea to have help with at least some kind of subsidized EMR system, or some way to have billing integrated and not have to worry about as much payment to third-party billers, not as much payment for translating services, interpretation services, and telehealth services that are integrated into our EMRs. I think that's kind of the next thing that I'm going to try to focus on as part of developing ideas that the state can figure out how to help subsidize and help pay for small clinicians too. And I really I want to, at least in my own mind, rethink the way that we're dealing with problems using the value-based payment model, as far as trying to figure out who are the best people to help us make these decisions, and incorporating other people outside of this group too. Because I think, when we first started at our first primary care council meeting, there was over 60 people, and there was this, huge spirit of all the folks and providers that were there. And I think we need to reinvigorate that, not that group of people specifically, but we need to definitely have as much motivation as we had on the day that we started. That's all.
That's all, not a lot, just a little, just a small amount. Thanks, John. Appreciate hearing from you.
Elisa, your microphone sounds much better, whatever you
Oh,
did.
good. Someone pointed that out and I picked a different microphone. I'm so glad. Thanks for letting me know. Anyone else want to comment on what they're seeing here or with their families? I have a very small positive. My kiddo's sick right now. He woke up this morning with a really sore throat. I never can get into his pediatrician, but I tried this morning and we got in. We got an appointment same day. So at least for this one moment, this one time, it's the first time ever since moving to New Mexico that we've gotten a same day appointment with his pediatrician. We've always had to go to primary care. So maybe a little glimmer there. So, all right. I'm going to try to stop sharing the whiteboard here. Close whiteboard. Thanks, everyone. We'll take those notes back and look at them and really sort them and figure out more about, if there's some things in there we can tackle. But I think that's a good place to start for, just continuing this conversation around where do we go from now, for now, in this moment. All right. Get our slides back here. Okay. Timing. Timing is everything, right? We did last time talk a bit about some interest around revisiting our mission, vision, and goals. So I wanted to just ask you all what you thought about the timing for doing revision, a whole new set of mission, vision, and goals, keeping pieces, updating pieces, and then also thinking about, what's the purpose of this revision? Is there just something that's missing here? Do we feel strongly about the work and how we've laid it out, but there's just a piece, something that maybe we just identified on that whiteboard? I'm actually going to call on Maggie because I know she and I talked a little bit about this.
Okay. And this is about the integration with behavioral health?
Yes.
Yes. We are, I think like everyone, we are trying to keep focused on the goal ahead in the presence of a lot of uncertainty. Now, we hit some of that uncertainty this week or this last week when there was a direction to cease the ARP funds, which was affecting our association as well as many of our members. And then there was a hold put on it by a district judge or federal judge. And now that's going to come back around next week to be revisited. So part of the resetting of the goals is, I think, having a way to articulate or maintain what our overall vision, our overall purpose is. The Provider Association executives this week met to talk about what they were doing. And so they had some really concrete suggestions. Suggestions like revisiting your policy manual and your grant applications to make sure that your language that you're using is consistent with what the expectation is. So we're trying to do some practical things. There was in some other work that we're doing on developing the data system. I think Lisa knows quite a bit about that, but in that process, we had identified making behavioral health providers as primary. That hasn't really developed. That, as far as I can tell, that discussion and planning hasn't really developed. I do think, and this is the conversation that Lisa and I have had, I do think that really figuring out the best way for behavioral health and primary care to integrate around the patient's needs is going to be a partial solution to some of the access issues. And I just haven't seen the movement go forward to really address that and figure it out. So that's my recommendation, is that if we're going to revise the goals, let's make sure that we have been intentional about what the role of behavioral health in primary care is, and vice versa. And I think that would be reasonable. Overall, in terms of revising, I think we need to just balance what we want to see happen and what is realistic in terms of what's coming down the pike. Because we're kind of past the point of we don't exactly know what it's going to be. We have a pretty good idea that Medicaid is going to take a major hit. That may not occur, but it looks more and more like with the budget discussions that are going on, it looks more and more like that's going to be something that we need to deal with. So there's a lot of things that need to be done. Knowing what those are is kind of a challenge right now, but I think we need to balance between staying focused, our eye on the prize, so to speak, as well as being able to navigate what's coming down immediately in front of us. Is that what you wanted me to say, Elisa?
I wanted you to say whatever you were feeling.
That's what I'm feeling. That's what
Good.
I'm feeling.
I just know you and I had chatted a little, and I wanted you to have an opportunity to share here too.
Thank you. Thank you.
Val?
I can unmute. Thank you. Yeah, and I'll put my hand on. Thanks, Maggie. I think that's right on. I mean, I think the two things that I guess in terms of timing, I think it's a good time to look at and make some revisions. I think that the overall mission vision, I think those are still very similar to what we've been asked to do and what we're trying to do. But I think that there is some real opportunity to give where we can sort of be the most effective in the next couple of years. I mean, I think the influx of behavioral health funding is a significant opportunity, and obviously behavioral health is a really critical part of primary care. So I think we do want to make sure that our work's reflective of both that challenge and that opportunity. So I'd love to see us, think about how to incorporate that into our, sort of pillars or mission or wherever that fits. And then the other piece, just from the last exercise, I guess what sort of struck me is that I think we've done a lot of work in increasing Medicaid payment rates for primary care and going into a period where that may be more challenging. There seem to be a lot of comments about sort of the other side, like how do we contain cost and how do we simplify structures so that instead of, billing 14 different codes for 14 different payers. I think that we have a real opportunity because New Mexico is such a heavily Medicaid funded state that we sort of inch towards the single payer system, right? Because there's such a large Medicaid population. So how do we streamline billing, value-based payment requirements, enrollments, malpractice, all the formularies are a really great example and something that there's really good work happening on. So I think all those pieces that make the logistics of practice easier also make it cheaper to do. So I think that helps the financial question, but I think just like for medical professionals, there's this idea of burnout and how do you move from the administrative burden to providing the care. I think on an organizational level, that applies too, and I think that could be really key to retaining providers here in New Mexico is how do we make the logistical side for both providers and organizations as streamlined and unified as possible.
Thanks, Val. Jessica?
Yeah, it was really wonderful to have the strategic plan linked into the chat and to pull it up because I, for one, didn't remember all the goals that the council has. So great revisit on this topic. And I feel similarly to other members that this is a good time to revisit and to think about potential revisions. As I looked at the goals, I was sort of queuing into the one about health equity. And I know that at one time we had a health equity work group. I was on that work group, and I don't know that we fully formulated all of the strategies, the assets, the opportunities, all these different things, and where we wanted to go with that. And I do feel that there's much work to be done. In addition to that, this concept of health equity, which is very broad and has many particulars to it, there's many forms of practice in health equity that are occurring on the primary care side as well as on the community-based side. And I think there's some opportunities to explore and discover that a little bit more on where things align.
Thanks, Jessica. Anyone else? So I'm going to try to restate what I think I'm hearing from you all and some potential ways that we can move forward. I don't think we'll be able to completely revise an entire mission and vision and goals in this 90 minutes. So I want to make sure that we have a path forward. I do hear that we need a better focus on behavioral health and primary care. And I think just to add to what Maggie said, we have an opportunity to really partner with BHSD in the work that they have to do. So they have a huge amount of work on their plate, including, how do we get Matt into primary care? And so I think you all are such a great thought leaders in primary care and behavioral health that having a dedicated work group and goal around behavioral health in primary care and that integration work and how we can support getting that MAT work done would be really important. So I just want to get a pulse from you all on your thoughts around adding a fifth pillar to our work, specifically around behavioral health. Agreement, disagreement with that? That would mean adding a goal and a work group specific to behavioral health and primary care work.
I don't know if that helps make it more integrated or less. It just seems like it has to be where we're, in our mind, it is always what we're talking about when we're talking about primary care. If having another pillar helps that, then great. If it means we think of it separately, then I'm not sure it's going to be valuable. I don't feel strongly either way, so just a thought.
Thanks, Erin. I think that's a good point. I think if we do create a pillar for that talks specifically about behavioral health will be we will want to be really strategic about how we explain what that goal is and what we want to accomplish with that goal. So thanks for saying that. Jennifer.
Hi, Jennifer Edgoose. Really appreciate hearing all of you here today. I'm the relatively new chair at the University of New Mexico for Family and Community Medicine. You know, certainly behavioral health is going to be critical. I think one of the things as I'm thinking about strategy and looking at our mission, vision, and goals is I'm curious about if we do need to re-examine our vision, which is really focusing on, it's looking like same-day access. Is that not correct?
Mm-hmm.
And although, you know, that is important, I think what I'm noticing is that really what we're trying to achieve here is ultimately a vision where we're really able to manage the health of the people of New Mexico, right? Same-day access is a component of that. But as we start to think of really what it takes to ensure health for people, that's if we had a broader vision, then things like behavioral health become an obvious pillar that you would add. And what I'm recognizing is that my colleagues, for example, in other specialties, certainly can talk about the importance of access to primary care, but I'm not sure they really understand the value of really how if we really move toward a value-based model, how taking care of a population is really what ensures better health outcomes. And it's not just same-day access. I think people sort of focus on that, and then it detracts from really how we want to revolutionize or restructure primary care, and how to invest in that in really more deeply meaningful ways. So I would say I would just like the group to just think about the vision statement as we think about the pillars as well. There may be ways to better align it all. So thanks.
Thanks, Jennifer. Jackie.
Hi, everyone. I'm new to this group. I'm Jackie Nielsen. I'm the Deputy Director of Policy at the Behavioral Health Services Division here at the Healthcare Authority. And I just want the group to think about as you think about your mission, vision, and goals and how you would change them, revise them, add any pillars is think about how this group can be effective when you're choosing a goal. And how, I mean, to me, this is just me personally, you know, behavioral health and primary care. And before I say this is like, including primary care, actual primary care physicians in our work is new, and it'll be new to us because our focus has always been behavioral health providers, people providing just, you know, behavioral health services, people with SMI, SED, SUD diagnoses. And so it's new to the division as well. Integration and wanting to do that is not new, but actually inviting and welcoming behavioral or primary care providers into the work will be new. And so I want to think about I want this group to think about how we can be most effective in rolling out integration work with behavioral health and also leveraging partnerships. So integration doesn't necessarily mean primary care has to do the behavioral health work, right? It's about leveraging partnerships within the behavioral health provider community to work together to do those warm handoffs for people who would need behavioral health services, and maybe thinking about how we can be effective in that manner than putting the burden on, or not the burden, but putting the responsibility on just primary care to carry out behavioral health needs. just something to think about as we shape this.
Thanks, Jackie. I appreciate that.
Hi,
John?
guys. Yeah, thank you. I raised my hand like physically, not with electronically. So thank you for
No
recognizing.
worries.
Thank you for recognizing that. You know, I agree with what Jennifer brought up, and I'm really thinking about the larger picture of what primary care is. I think is essential for that. I mean, I know the value-based payment structure is really important, and we're thinking about paying for quality, paying for outcomes, paying for those sorts of things. But it's a mechanism to provide adequate payment for high quality primary care. High quality primary care, as we know, is the basis of a functioning healthcare system. It improves outcomes, it reduces cost, it makes huge differences. And you know, there's the IOM report that came out on creating high quality primary care, I think is a really good roadmap to follow. It talks about training, it talks about payment, it talks about other structures. But it says in that we don't even need to talk about the value of primary care because we know the value of primary care. So when we start thinking about addressing issues, it's not just having that doctor in that clinic, right? So I always think about all the structures around that doctor that need to be in place so the doctor can be effective. And integrated behavioral health is one part of that. And so I'll give you an example. The Medicaid group just came down to Las Cruces last week, and we had some discussions, and we talked about how to address the needs of primary care. And one thing that came up was social barriers, right? How do I address a patient's diabetes? I think just treating somebody's diabetes is very downstream and it's very much Band-Aid. My question is why do they have diabetes? And what foods do they have in their communities? And what social structures and what built environments do they have that are healthful? And how do we build things around that, right? How do they get transportation? How do they pay for their medications? How? I know integrated behavioral health is a key component of that, but thinking about the social structures around that are really, really important. And that's where that value comes from. And so those are bigger thought processes. So I'm gonna put a period there. Everybody take a second to clear your minds and think about stuff. I know we're worried about Medicaid. I think the Medicaid fund, what do you call it? That $500 million that they put away, what do they call that?
Oh, yeah.
The House Bill
I'll go back in
88
the
or
slides.
Senate
Yeah.
Bill
The
88.
trust fund, Medicaid
The
Trust
trust
fund.
fund, right?
Thanks, Julia.
I think that's a really good strategy for the future of what we do with primary care, because what's happening is the state is investing in how the state itself can pay for the services that we need. And I think that's going to be really important. And then the state can reinvest its thought process about where and how we build these structures to cover for the services that are needed at the community level. But I can tell you, primary care involves integrated behavioral health, but it also involves, a social structure or social interventions to address the social structures that cause the negative health outcomes of our patients. But if you want to address those, you have to have primary care physicians in those communities. And there's good data internationally that shows the more primary care physicians you have in the communities, the less these barriers exist and the less those outcomes exist. So there's a lot of words, a lot of thought process, but I think those are things that we need to address. I see you nodding your head, Val Wangler. Tell me what you think.
I think you said it very well. I mean, I think that there are, of course, really large structural issues, and I totally agree that the state thinking ahead about having funding available when we need it, I think is really wise.
Thanks. Agree. I think you said that very well. All right. I'm hearing interest in continuing to work towards restating our vision. And so I'd like to revisit that in more depth in our next primary care council meeting. I think we'll be even more prepared to talk about that once we really get these work groups going for the goals that we want to achieve. I think for today, it would be really nice. We're going to have some breakout rooms right now. I'd like to have everyone kind of self-select, and you can hop around. We're going to have some time for the next 30 minutes or so. Be in a breakout room. Oh, I forgot I'm not sharing anymore. I'm a visual person, so I always want to make sure folks like me have an opportunity to not just hear, but see what's going on. Okay, so I'd like us to go into breakout rooms. I'm going to add a fifth one that is around behavioral health, not to establish it officially at the moment, but I think having some insights from a group of folks who might want to consider development of a more specific integration work group, a behavioral health focus work group. It would be great to get you all together. We have Keenan here. He's going to help in the equity work group. Goal 2 would be payment reform. Goal 3, technology. You'll see in a minute when I pop up the breakout rooms if you want to self-select. I know some of you want to be in more than one or have identified being in more than one group. Again, pop into one, stay for 10, 15 minutes, switch to another if you'd like. All right. We did put that strategic plan in the chat, so that's a good tool in our breakout rooms. Just some things to consider in the breakout rooms for our goal areas. And this is just to start getting us thinking so we're prepared when we relaunch these work groups. You know, what's been completed that's in that strategic plan? What needs to be prioritized that's in our strategic plan? What's missing? What's not there? And then for our new goal area, start thinking about what adding that goal might look like would be great. Okay. Give me 1 second and I will open up those breakout rooms.
Elisa, what time would you like us to be back in the main room?
Let's
goal?
come back at 11:05. Sorry, 11:05. That was a minute ago. 11:35. About 11:35.
Okay.
I'd like a PCC member to do like just a quick recap of the conversation when we come back. So we'll come back at about 11:35. Okay. And Jackie, I'd like to invite you into that room to just observe and help out with the potential BH goal area. Okay, here we go. You all should be able to join. You all see the breakout rooms? Not yet? Okay, hold on. Yes?
Yes.
Jamie does.
Yeah, just click on the little dots that say more, join breakout room, and then you'll get a list.
Thanks, that's helpful. And if you're not sure how, just shout out which room you want to go to and I can put you in it.
Okay, how do I get to her?
Let me assign you, do you want to be in the workforce GME room or a different room, John?
I'll start off there. I'd like that one
Okay.
in health equity, but GME is kind of my job. So
You got it. I'll pop you in there.
And I apologize, I'm late joining today. My name is Robin Napoleon. I'm with the Presbyterian Health Plan, Medicaid CMO. So would it be appropriate for me to join a room at this time? I just joined. I had a conflict, unfortunately.
Please, no worries. Yeah, you absolutely can join a room if you would like to, and listen in to what's happening in the room.
Sounds good.
Okay.
And how would I do that? I
Sure.
don't,
Do you have an interest? I can move you in there. Do you want to be in equity, payment reform, technology, workforce, or behavioral health and integration?
payment reform. Thank you.
You got it.
Thank you so much.
No worries.
Haley, sorry, I don't know what happened. Did I get kicked out of the meeting? Well, hang on, and I'm still not hearing you. Something is weird.
I was on mute, sorry.
Oh, okay, that makes more sense.
We went to breakout rooms. Did you want to
Okay.
join one of the breakout rooms?
Sure, that would be great. Sorry about that.
That's
My mom
okay.
came over and needed a couple things.
No worries. We
Couple
all
things.
gotta just do what we gotta do.
Right?
You know?
I hear
Um,
you.
So we have a breakout room for equity, one for payment reform, one for technology that currently has no one in it, so probably don't want to join that one.
Okay.
Workforce, and then one to consider a new goal around behavioral health and integration.
How about equity?
You got it. I'll pop you in
Thank
there.
you. All right, thank you. Nice to see you. Take care.
Nice to see you too. People should be coming back into the main room here. We'll give a couple more seconds here for people to be able to come back. Okay, welcome back, everyone. I popped into the different rooms and it sounded like there was a lot of great conversation going on, so thank you. Let's have some folks just provide us some key topics they discussed in each room. I'd like to have a PCC member just kind of recap. So we'll start with the equity room. If someone from the PCC was in there that wants to give us a recap. Maybe Anjali.
The health equity room.
Equity room. Do you want to give us just a quick recap of what you discussed in your room?
I would invite anyone else who is there to also share, but I think we looked at the 2023 strategic goals and plans for health equity and talked a little bit about the context of, I think we met less as a work group in 2023, and the DOH and HCA had a lot of new things on that strategic goals list. So I guess comparing the 2021-22 one to the 2023 one would be great. We also thought it would be helpful to understand where the DOH and HCA are on the various things that were there, and we're excited about restarting the health equity work group meetings with some regularity to perhaps come up with new goals for health equity for the primary care council that are broad as well as doable. And it came up also to potentially look at take a health equity lens to all of the pieces of work that the Primary Care Council is doing, including payment reform and otherwise. But I think a desire to start meeting again and maybe kind of figure out what from the list from 2023 makes sense and come up with some new goals. If anyone else would like to share, please do. Yeah.
Great. And I'm so excited that Tristan is here because we have now someone that can help organize these meetings and make sure that they are happening. So thanks, Anjali. Someone from the payment reform room.
I'm going to go ahead for our group, and I'm going to keep it very brief because I know we've only got 5 minutes. But obviously for this, the payment reform, we have a lot we can check off as, you know, not completed, but underway. And there was definitely agreement on the continued collaboration between PCC and HMA to make sure that certain things that we're obviously still rolling out, like the patient experience, quality measures, things like that, that we're ensuring this group is providing that feedback and kind of continuing to guide that work. There was a lot of other things. I will just say one good idea that came out was potentially having, I would call it a listserv. I don't know if that's the right terminology, but for each work group, so that in between work group meetings that people can just throw out ideas and kind of discuss that way, since everyone's got very busy schedules. So that was an idea. And obviously, I think continuing to modify our activities and objectives for this goal.
Great, thanks, Tristan. No one was in the technology room, but I know John Helm and I have met and talked several times. And this did actually come up in one of the rooms I popped into. There is some interest around what a statewide EMR EHR might look like. You know, it could, but it wouldn't necessarily have to be mandatory. You know, what would that look like in creating more efficiencies for our providers? Because there's, you know, and beyond that, you know, looking at the codes and can we simplify some of that system? So I think there's a lot of work that can be done in that technology work group. Workforce and GME. Somebody want to talk about that?
Of course, I was in that work group, and I will. I only have 10 minutes. Just kidding. So
We'll take a break and you'll still be going. That's okay.
That's about right. I think there were some really good discussions in the workforce development. I think we continue to want to focus on primary care and getting primary care physicians in rural communities. I think that's really important. I think other major areas is what community needs exist, including behavioral health, obviously, which is huge. And then thinking about the future, because we have things like obstetric deserts and other general surgery deserts, and you know, people that live in relatively large communities without services, and it's really focusing on what services are needed to address those needs. I talked about wanting to address funding issues and training for training residents in FQHCs, critical access hospitals, and independent psychiatric facilities. And it's because these facilities specifically are not eligible for indirect funding or Medicare or Medicaid funding based on the structures of the laws and regulations. And is there a way we can address those regulations to allow money to flow to these places where the patients are and where the physicians need to be training? Because we know, as I've said before, where you train them is where they stay. And so really, I think thinking about how we do training in FQHC, critical access hospitals and independent psychiatric facilities, I think is going to be important. And then we talked about sustainability of programs. As we move forward, we really need to sustain our programs. You know, a program at an academic health center has a lot of resources around it A program in a very rural community has less. And how do we create strategies to maintain these programs so they can continue moving forward? And I think there are strategies moving forward in the state right now. We're talking about the UNM Hidalgo Medical Services collaboration and just trying to figure out how to build sustainable models. The next thing that came up was creating a supportive, safe practice environment for physicians. And what came out was med-mal reform specifically. And, we can train a lot of physicians in a lot of these communities, but if they have an environment that where they feel unsafe and they feel like they're not supported, that puts the ability for them to even stay in the state at risk. And so we're losing a lot of physicians. We know that New Mexico is at huge risk and has been losing physicians dramatically. So med-mal reform definitely came up as creating a safe practice environment for those people that we train. And then really interesting, a discussion came up about creating shared strategic, I guess, planning or activities of facilities. So, what ends up happening is medical facilities end up competing and trying to get the highest dollar and not necessarily thinking about how they could share resources to provide services to best address community needs. And I thought that was a brilliant idea. It wasn't my idea. It was actually Brian's idea. But, and it kind of revolves around accountability and how are these organizations accountable for the monies that they get, both federal and state, to provide these services. So we went down a really long rabbit hole. But we think there are some low-hanging fruit, and I think specifically addressing funding needs in FQHC's critical access hospitals and independent psychiatric facilities are things that we could address, whether it's through regulation or whether it's through other funding sources. And anybody else, please join in that if I missed anything. Alex, Brian, no? Okay.
Nope, you did a great job. Basically, we know that the workforce work group has plenty to work on and we have some good goals set. So
Great, that's good. All right. How about for our behavioral health integration potential goal?
So this is Jamie. I'll report back for the group. There was definitely consensus that behavioral health integration should be elevated as a topic and as something to address. But we did take to heart one of the comments from the larger group, is that better done by carving out and creating a separate committee, or is it done better by integrating it into the existing committees? And to kind of get to a decision or a recommendation about that, we thought about what does integration look like? And we're really thinking about it in two different ways. One, my primary care doctor should be able to treat my moderate to mild depression, anxiety, or substance use disorders. So there should be some integration in what my primary care doctor can provide me related to behavioral health needs. And then the second is if it's more severe, behavioral health providers having the ability to make those referrals to specialists within the behavioral health field. So we were looking at both of those, and each of those take work that the workforce and graduate medical education training group does. The technology group needs to be involved in how do you support that integration. The payment reform needs to be involved in how do you support that integration. So our recommendation is that we create a system, either there is a person in each of those committees that always raises their hand and says, what about behavioral health integration? What about behavioral health integration? Or that this group creates some specific action items that are then assigned to each of those committees. So that's a summary of our discussion and recommendations.
Thanks, Jamie. All right. I want to give everyone a little break. That was a lot of deep thinking. Thank you. I think we'll take back that recommendation and think about it and If you all have strong feelings either way, if you want to put that in the chat, that'd be great. I'm going to pop up a poll for you all to take. Just letting us know what EMR you're using. I think that would be helpful just to get a picture of, what is the diversity of EMR EHRs that folks are using. And we'll be back at, how about 11:55? That way we can stretch our legs for a moment. All right, I'll pop that up and see you in a minute. All right, if you haven't had a chance to answer the poll and you'd like to, I'll give you another about 10, 15 seconds and we'll get that closed. All right, I'll share the results for you guys. And Alex or Tristan, if one or both of you can just jot down the answers in case sometimes I can't pull these things back up in in the Zoom later. All right. Welcome back. I hope everyone had a chance to stretch your legs, grab more coffee or water, and you're ready to tackle the next half of our meeting. Chris, you have your hand up. Did you have a quick question? You're a mute.
Sorry, it's a really quick question, Lisa, because I'm really confused. The question of the poll that you just sent, and you had mentioned that there was a move to see if there could be did I understand correctly, a standardized electronic medical record or health record? Because
I don't know. I don't know if I would describe it as a move towards that at this moment. I think there's conversations happening about that and whether or not that's a possibility to move in that direction.
Okay.
That's kind of where we're at right now.
Okay, because my confusion is that the closed loop referral system, or at least the Find Help HCA group on this, is apparently looking to see, what kind of either standardized screening forms for the social drivers of health hospitals and health systems have. And so I'm just curious, is it the whole electronic medical record, or is it just the screening form for SDOH, because the coding is different and everything else? So I'm just curious if they're collaborating, talking together, or anything else, because that threw me for a loop.
Yeah, no, that's a really good question. I know I know about this much, so we might have to get back to you, Chris. And I know there's a lot of work happening. Roberto's working with our Deputy Secretary, Kira Ochoa. They've really dedicated a lot of energy and into this. My understanding is that there is integration with these systems with Find Help. That's my very basic knowledge. I would like to invite the closed-loop referral system folks to come to this meeting at some point. I'm waiting until they're ready for feedback from this group before we invite them, because I really want you all to have a chance to provide feedback, not just get a report out. So hopefully that happens soon. All right, let's get going. Share the, oops, probably don't need to see that anymore. Give me just a moment and we'll get our slides going. Oops, let me switch. There. That should be the right way. Okay. All right, I'm going to invite Alex Willie, who's put a lot of time and energy into creating some bylaws for this group, to speak and let us know where she's at and what kind of ways that we can get some information, advice, feedback from you all. Go ahead, Alex.
Yeah, hi everybody. I know after we've been kind of in the actual work that you want to do, it's a little less fun to switch back to the bylaws. Fully understand this is not the exciting part of it, but this is something we've been working on for the Medicaid Advisory Committee and the new Beneficiary Advisory Committee. So it was thought it would be nice to create these for the primary care council, these because they don't really exist. You guys have a bill that kind of dictates the work that you're doing. And then there's an Open Meeting Resolutions Act, which, you know, comes out periodically and kind of is the rest of your bylaws. But this is just a good tool for you all and for us as a state to kind of have a place that you can look to as what is the work of the PCC, what is expected of you all as members, as us as a state, and what, you know, we've had this kind of lull in the work. And I think this would be a good driver of a place to check in and the expectations for us all. So yeah, these are just, if you want them as resources, if you want to check in, I don't think you all are looking at the bill often of what the PCC had come from, but it is a good place as a reminder of what the core of this work is and where it came from. So here are the two documents that this is built out on. So honestly, the bylaws as a whole are not revolutionary. They're not wildly different from this. It's taking this language from these two places, merging them into one and adding some, building some more information out of the expectations of what we're doing as a state, and then for you all as well. So right now I've drafted just a really standard bylaw. It matches how we've done it for the other committees that we do. And there's, you know, some really basic language in it around how you all want to shape this, but I'd like your feedback because it can be shaped if there's things missing, if you want, you know, very clear outlines of how this work works or what the state is doing or the roles that you have. This is the place to do it. So there's a couple things that haven't been included in the past that we could really look at, and I've made a survey because I know you all love having more surveys to do, but it's the easiest way for you all to give feedback. So in the slides as well as in the chat, there's the link to the Adobe draft of the bylaws. The survey is here. I'm sorry, I'm dying from allergies, so that's why I sound and look like this. But it's here for you to review. I didn't want to break it down and go line by line because it's tedious. I have in the draft in the PDF made it clear where each chunk of language came from. So you're not trying, there's some aspects like the bill there's not really a place for your input to make big changes, but there's other components that you can put changes on. So basic questions in the survey, it's not long. It means you can read through it if you really feel like there's something that would help shape it. And I think a couple places would be term length of you all, if you would like to see more turnover, how we're bringing people on to the PCC and what that looks like, as well as, you know, for the chair, we just brought Val on, it's fantastic. But if you want to shape kind of how often you look at having a chair again, you know, these are all the standard bylaw things. Again, I understand it's not the most thrilling aspect of the work, but you can really use it as a way to shape your expectations for the PCC as a whole and for us. So if you can all take a look at it, kind of here's the timeline we're looking at. I did 2 weeks for the survey. You can take a look, do the survey, send back any information that you want to give on this. We will review it again with OGC and then bring it back to you for your final approval in the next PCC meeting. I can answer any questions if you want. All pretty straightforward, but it is a place if you see something or is anything you've seen before in bylaws that you really want to insert into this or feel like would help shape the work you're doing, let me know. It's flexible. Nothing in this is something that, you know, we all thought you have to have this. So it's really up to you all, but it'll be a tool to reference to in the end. Yeah, so that is the entirety of my bylaws talk. I don't know if anyone has, there's no feedback right now, but if you have any, you're welcome to give it.
I'll pause for a moment. I know there are so few people, but there are a few people that can get really jazzed and excited about bylaws. So if you're one of those people, we definitely invite you to participate in providing feedback because you may be one of a rare few. All right.
Yeah, I mean, I will say that this was a great tool. The reason it's brought here is it was a great tool when we're trying to shape the Beneficiary Advisory Committee, which I know Josh doesn't start for 5 minutes, so I might use this moment, Lisa, if that's okay,
Sure,
to mention
go for it.
that. So we just wrote the bylaws at the draft for the Beneficiary Advisory Committee, which starts in July per CMS regulations. So that'll be coupled with our Medicaid Advisory Committee. So probably in the next week, maybe slightly longer, we will be launching the application for the Beneficiary Advisory Committee. I will make sure that you all see this and get this information as well, because you are great resources for this. So you can, if you have Medicaid beneficiaries who would be great in this kind of input and would want to work with the state on that, that would be fantastic. So when it's launched, when the website's up, when the application is live, I will make sure that you all get that information. If you have questions, you can direct it my way. But I think it's going to be a really fantastic tool, and that'll start the first meeting in mid-July, and they will work hand in hand with the Medicaid Advisory Committee and report out to them as well. So we'll get kind of a different perspective that the state is really not getting right now. So look out for that and send people our way, because I think we'll need it and we really want great applicants for this.
All right. Good plug, Alex. Appreciate that.
Sorry.
No
Send people my
worries.
way.
No worries. All right. Welcome, Josh. Thanks for being here. Looking forward to hearing from you. All right, go for it.
Hey, good afternoon, primary care council members. Good to see all your little glowing faces on the screen. Josh Nelson here, strategic operations manager for the Medicaid division, medical assistance division, I guess technically is what we're called. Wanted to give you guys a update on the primary care payment reform, little status updates, what's being discussed, where we're headed, those sort of things. So just a little program overview. We are continuing to work with the Health Management Associates on this project. Last week we did 3-day training. Saw several of your faces amongst the trainings, and so it's good to see you guys. It was well received. I think really great feedback, collaboration. Got a lot of good, great questions and concerns and things that we're taking back and just continue to use to consider how we approach everything. Right now, the Tier 1 launched summer of 2024. We began enrollment in September, but as of March, this last month, we had over 100 practices at almost 400 locations with over 2,500 providers enrolled and currently participating in this model launch, which has been really great. We are right now still trying to look at what is the difference between who has enrolled and who hasn't enrolled, and what are those numbers of possibilities, who are missing and who is participating. We don't have that exactly pinned down. We have some preliminary numbers that we're looking at, but the scope of availability and eligibility was a little too big. We were first looking at who all are the eligible providers for Medicaid, but that scope goes to 100 feet outside, 100 miles outside of the New Mexico borders. And we thought that was an unrealistic look to go all the way into Tucson and Amarillo for the eligibility. So we're trying to pare that back a little bit and get a more realistic number of who are eligible practices and providers for this program and to see who we're missing. Since the beginning of implementation, the program team has been assisting practices with meeting program requirements, talking through data collection, reporting, encouraging registration, and lots of just one-on-ones, emails being answered, in-person trainings. We are right now doing the bi-weekly office hours and just trying to continue to socialize and answer questions and get things more cohesive on our side and ironing out all the wrinkles. And there are a lot of wrinkles still that we're still ironing out. What decisions are still being discussed? Right now, we're preparing for January 1st, 2026, because there are several pieces that kind of roll out on that the January 1st timeline, which was going to basically be the rollout of the Tier 2 and Tier 3 models. We're finalizing the quality metric timelines for the 2026 to 2028 rollout, refining the incentive framework, and what that looks like to encourage the maximum participation. for tier 2 and tier 3. We're trying to determine when and how practices will select which tier they want to kind of come into. And then we're also facilitating the attribution process across all 4 MCOs. So if you weren't aware, we have tasked the 4 MCOs to work as best friends to come up with the best attribution process in the world. I don't know when we're going to get there, how we're going to get there, but that is what they are tasked to do. And so they have some guidelines, and they are working amongst themselves and are expected to come back to us with kind of like some round draft questions and concepts that we'll work with together to see how that is coming along. We are also talking about the expert training requirements and actually trying to build in some flexibilities in there, because the first round of instructions, we've realized we got a lot of feedback on time constraints and kind of overburdensome for several providers. And so we're trying to relook at that and give some guidance on how to do that the best way possible, and kind of pull some of that burden back off of providers, but also continue with the heart of the expert requirements. And then we're also waiting for CMS to approve our preprint application for our directed payment information for the incentive payments for these last couple of quarters. Right now, none of the practices or providers have gotten any incentive payments because CMS has just taken their sweet little time in getting us the approval, but we do anticipate that approval will come soon, and soon would be in the next month or 2, so that we can get those payments out to all the participating practices and providers. Next slide. I was asked to kind of speak to what kind of has been finalized. Right now, we would say we're pretty firm on the quality measures for the first 18 months, as well as the structural measure timeline through October 2025, which would basically be the expert and patient experience of care. We are rolling out a patient experience of care tool and process. We recently finalized and started to first socialize that we are developing a tool that will gather that information for the patient experience of care. And we did that last week. The first socialization of that happened last week in the workshops. Also got some feedback on that we are going to be doing some tweaking to that patient experience of care tool and how we receive data. We're working with our data intermediary, NetHealth, to kind of create a little bit of flexibility in how practices give that information, whether they use our tool or the idea of being able to use their current survey systems to gather that information. We want to try to be as flexible as possible there, but also continue with getting solid data that is going to meet the program's requirements. I do want to make sure everyone here knows this, and we said this at the last PCC meeting. We brought the payment model work group into our working PCPR work group, and we do a monthly meeting where we highly encourage any PCC member who wants to help direct and guide us where we're going to be a part of that work group and be active, because that is one of the direct and most influential groups that we have. It is like picking up, and we are trying very hard to keep everyone in that work group, all the stakeholders, which includes PCC members, but as well as a couple of the other other stakeholders, which includes PCC, MCOs, those of us here at the Healthcare Authority, NetHealth, HMA, and Mercer are all working together in that work group to continue to guide and direct where this program is heading. Our next meeting, I just saw that. Let me look at my calendar real quick and I'll tell you. I don't have it off the top of my head. Is April 30th at 11 a.m. And if you want to join that group, if you would actually email Margot M. Swift at healthmanagement.com, we can get you that invite and make sure you can be there to be a part of that. It is meeting monthly right now. We want you there to provide input, help us to make decision making best possible, make it make the best decisions possible for this program. And we really do want you guys there to give that input if that's something you're passionate about. Yeah, that is kind of a quick little update and overview. I see chat stuff and I want to make sure I address those things, but I don't have it pulled up.
Yeah, if anyone has questions for Josh, feel free to pop on or raise your hand as well. We have a little bit of extra time for this section. Yeah, please attend. If you have the time, if you're wanting to be part of the payment reform work group, this is another way to just really get your voice heard. All right.
Thank you
Thanks for all
guys.
the work you're doing, Josh. Appreciate it.
Absolutely. Thank you guys. I appreciate everything you guys do as well.
And we'll keep inviting you back to this meeting. All right, great. All right. I also wanted to give just a quick update, and Josh, you may have more to say unless he might have left. He's a busy guy. You know, on March 12th, CMS did announce that the Innovation Center models are ending early. So we had applied and were accepted as a state to this Making Care Primary project, which basically was aligning our VBP models with a pilot model with Medicare. And unfortunately that we did get the announcement that that is ending early. And so that Making Care Primary project really didn't quite get off the ground fully, I think, but unfortunately that's ending. Val, did you want to just hop in?
I just had a question for you on that, Elisa. I mean, I think that, you know, the alignment between Medicare and Medicaid on this was really important and really helped us leverage our efforts here. I am just curious, you know, with a lot of the changes that have come down from the federal level, there's then been some, you know, legal pushback or court action that's sometimes influenced that or reversed those decisions. Is that something that's on the state? I mean, do we have any ability to say, no, you signed a 10-year contract with us on this and we want to continue it?
Let me get back to you. That's a really good question. I'll look into that and come back.
Thank you.
Right. Yeah, so what does this mean for payment reform? You know, having alignment across all payers was our goal ultimately, and that will really help adoption and provider burden. And there's a lot of reasons that that's important. Jen, I see your hand up.
Yeah, I think maybe Val said this, but I also am wondering, you know, if we can get follow-up and feedback around the regular Medicare Advantage programs, because I hear that that is also a little bit under scrutiny right now. And I know a lot of our sites also kind of work in that area. So, and maybe that's exactly what Val just asked for too. But I would love to kind of keep us posted as a council around those federal changes, if any. Thank you.
Yeah, I think starting with our payment work groups and digging into that there, just to be informed to start with, is a good idea. All right. We will definitely keep everyone apprised if there's any additional changes.
Lisa, I'll set up some time with you on the multi-payer alignment work as well, just to debrief you on the effort that was going on and the abrupt stop to it by federal mandate.
Great. I would love to just kind of get more information about that.
Yeah, just look for an email from me for some time.
Great. Thank you.
Thank you.
All right. Aligning PCPR with, yes, so, Jennifer just had a question in the chat around aligning the primary care payment reform with the MCP metrics. We had done a lot of work collaborating with the Innovation Center on aligning our metrics and what was required in the programs and how it was set. They also had a 3-tier program. And so it's really sad to see that work kind of go away, since there was a lot of work done to align. So yeah. All right. Keenan, invite you to talk.
Sorry, I was finishing a bite of carrot, sorry.
No worries.
So I'm going to give a update on the preferred drug list, which we're going to give a bid will be coming out shortly. I just want to say we're in a new office. If you hear some construction noises behind me, I apologize, but we do what we can. So New Mexico Medicaid will be issuing a request for proposals imminently for a preferred drug list that we think will go live in 2026. The way a preferred drug list functions is very similar to formularies by insurance companies, but they're typically less exhaustive. We're not trying to say down to every specific option what you have, but more of the most commonly used agents. And decisions will be made in a similar manner as you see for formularies with a P&T providing the initial evaluation and recommendations, and ultimately the chief medical officer for Medicaid, which currently is Alana Dances, will be the one signing off on it. Why this is important is it gives the state more control over how medications are being used, especially among its insurance plans. As you know, we have 4 MCOs, and I will say of our 2 biggest MCOs, there's not necessarily alignment between what they recommend. So when a provider has to say, oh, this person, is this person Medicaid, this is what I can use, which of the 4 MCOs are they, and what is their preferred first-line agent for, say, a GLP-1 for diabetes? And I can tell you that the 2 biggest don't align here. So there's actually a lot of back and forth and a lot of requests that get made for one versus the other that can be a burden on provider and patients. It also creates a barrier where patients may not feel comfortable leaving between one MCO to another because they might lose access to the medications they feel, stable or, they're at the right goal and they don't want to lose them. So by doing this, we think we'll have better alignment. This is something most other state Medicaid programs do. So 45 states have either some form of a preferred drug list, or they've actually just taken over all of pharmacy management and don't allow any of it by their MCOs. You can see some variance in whether it's just for fee-for-service, whether it covers just the outpatient, like prescriptions you would get at a Walgreens or a CVS, but also covers medications that are given in the infusion clinics within different practices. So we're trying to be as aligned as possible. So we will be including our managed care and what's also known as these provider administered or these outpatient administered medications in our PDL. Next slide, please. Before I go over the risks and benefits, does anyone have any questions, comments, concerns so far that they want to discuss?
I just had a question about, you said that states range from PDL to complete management. What does the other extreme look like?
So the biggest extreme, we're on one side of the spectrum. We are the extreme without a PDL in anything, meaning that we just kind of allow every individual insurance group that we employ to come up with their own list of medications that they do and don't prefer. And so that's one extreme, basically complete private industry. I shouldn't say private, but complete industry management. The other extreme would be states that have completely carved out pharmacy. So that's where the state has one PBM at the most extreme level. They run it themselves. They don't give any money in their capitation rates to managed care organizations to manage pharmacy. They do everything themselves through their own internal system. And there's a spectrum across the board. Like I said, most states have some form of a PDL in place, if just alone for fee-for-service population, but many have a fee-for-service population plus some big classes of agents as well. Individual classes and their MCOs that are on their preferred drug list as well. So that's kind of the spectrum you can have. So it varies in gradients along there.
Keenan, this
So,
is John.
yeah.
I think this is really, really important and valuable. As my new role of CMO at La Clinica, the first thing the providers ask me for is a regular posting of the drug formularies because they have to be able to get on them. And not only are there 4 different formularies, they change regularly. And so I think this would be, helpful in our patient management.
Yeah, so tentatively, we're going to have at least 4 P&T meetings a year, as well as some ability to do off-cycle evaluations if something changes, right? This does include some state negotiation of drug costs as well. And that's important to realize. This is actually one of the major ways pharmacies can cover more medications is because they have a preferred drug list. So for example, I'm not guaranteeing we're doing this or not. I'm just using this as an example. Some states cover weight loss medications for their GLP-1 classes for weight loss, not just for diabetes. They're able to do that because they go to the drug company and say, we'll include you on our formulary. You have to drive this cost down because it's like $1,500 a month whack cost. Well, $1,300 a month per patient, right? And so they're able to negotiate some of those costs. What I want to realize, because that happens, that might be more cheaper for Medicaid on a whole and allows us to provide more medications for patients. But that also might mean that a pharmacy has to buy a more expensive version of the medication to stock, or the hospital or the insurance company. This is a known factor, and we will, in all likelihood, increase our capitation rates to cover this. So in the end, it saves more money and allows us to access more medications for patients. It also means there's more cost in the system. The net is a positive, but I just want to make this point because this is one of the big things you hear after you implement one of these is people say, now I have to stock this much more expensive medication. How is it saving money? Because at the final end, we get a rebate from the company that makes it, so we can actually purchase and provide these medications. And so I just want to make sure that that point is clear so you guys know that in 6 months when you hear this comment, you'll understand why the state is set up in this way. But we do think overall having a unified system that updates regularly makes it easier for patients, makes it easier for providers, allows to transfer between one or others. There's also more transparency. Obviously, when the state holds a P&T meeting, it's a little easier to know what's going on than when a national, when is United's versus when is Blue Cross's versus when is Press, right? That's 4 you have to keep track of. So we're hoping that this moves in a more positive direction and gives us a little more oversight to the way medications are being managed in the state. Any other questions or comments I can answer on that?
Keenan, could you go over, please, the timeline once more? You touched on it, but.
Yeah. So the bid should be going out any moment now. You basically, the way rates work, you can't just turn it on once the list is done. You have to align with kind of set rate times, and it will require some CMS approval at the earliest. And the goal tentatively is January 2026. But again, it's not like if we don't do January, we can do it in February. There's kind of like preset windows we have to go into. And so that's the goal is January 2026, and we'll stay up to date on that as we go from there.
That's great. That's quick.
Yeah, it's quick. It's a lot of work. So, but we're excited to get it going.
I imagine this would be really hard to know, but do we have data around, how often patients are not able to access medication because something's switched on formulary? I can imagine it'd be hard to collect.
So for Medicaid, we do get a fair amount of reporting from our MCOs. For the specific, we could probably get you a rough estimate by making some assumptions off the data they report. it becomes difficult to say because, like, for example, Blue Cross Blue Shield is a semaglutide institution where press is tirzepatide. I'm not saying one's better than the other, but the most common request they get is, most common request press gets is for semaglutide, let's say. Well, they might have a high denial rate for that, but as soon as they switch to the formulary agent, it's accepted. So is it like people just aren't getting medications whatsoever, or they're getting just something else within that class? They just have to know what the right formulary agent is. And so there's some nuance there that we're trying to get a better, like, how do you monitor this, that they never got something in the diabetes class, or they waited 3 to 6 months before they got something because of all this paperwork, versus the doctor submitted one, they got the rejection, 2 days later they switched to a new one, and if we all had the same agent, it'd be much easier, but there was really a minimal impact. And so that's where we're trying to really fine tune some of our reporting now.
Thank you.
Keenan, I had one other question. Is there any thought to combining this, the PDL and the list with the state health benefits plan along with Medicaid?
There is some discussion, and there's the it just switched over from general service to the HCA, but it's not within Medicaid. The Intra-Pharmacy Purchasing Council, Intra-Department Pharmacy, something like that. There's a website, IPPC, that looks to try and create better strategies and alignment between them. I would say that there are strategies in the future that could be pursued if that's the way the state chose. This specific piece probably plays into that, but we can't necessarily put non-Medicaid patients on a Medicaid rebate system, if that makes sense. So the large answer to your question is yes, there's opportunity. This specific aspect has some wrinkles in it that make it a little difficult. Not impossible, but there would have to be kind of some more planning through.
Great. Thanks, Keenan, so much.
Great questions.
For all the work you're
appreciate it all.
doing. Yeah, I appreciate it.
As it gets around and we get it awarded and we're in the work, we'll let you guys know what the status is and as we move forward.
We'll definitely invite you back for sure.
Thank you.
Once a PCC member, always a PCC member, Keenan. All right. We have covered the majority of our topics, all of our topics for today. I do want to pause for a moment and just reiterate that we will be starting up the work groups. Tristan and I are going to work closely together to start to send out calendar requests to make sure that we can get all the right people together. It is incredibly difficult sometimes to coordinate that. But I think Tristan has some really good ideas also about some offline participation and ways to keep this work going regardless if everyone can attend or not. Our next meeting is July 10th, 10 to 1. We will also start sending out invites ahead of time to these meetings, July and October. We would like to propose January 8th and April 2nd. Those are new dates, so they are not set in stone yet. Please reach out to Tristan and I if you have any major conflicts on either January 8th or April 2nd. That way we can adjust accordingly if people just, enough people say, no, that doesn't work. For next quarterly meeting, we would like to do a report out on our work group progress. What have our work groups decided is a priority to work on in the, in the immediate timeframes that we have? Membership consideration. We do have a few gaps. And so Tristan and I are going to go back and make sure that folks that we're missing that are outlined in the bill, that we start making sure that those positions are filled. And we may have some more announcements on members joining GME work. We are currently getting our awardees for the most recent residency expansion work, getting those together. So we'd like to do an announcement on those grants, as well as we'll have them also give some work group progress. There's a lot of work that that group wants to get going. Workforce, oh, I missed a word here, dashboard. We'd like to invite the workforce dashboard folks. I don't know if Julia's still here. The Hospital Association is working with, and I'm going to forget the acronym, one of the education. ICASA, thank you, to develop a workforce dashboard. So we'd really like to invite them to talk about the work they're doing. And then we would really like to invite the folks working on the closed loop referral service, which was something that this council was very interested in getting launched, and get an update, both an update and some opportunities for provider feedback on that closed loop referral service. If there's anything else you all are interested in having us add, topics that aren't here that you want to see happen, please reach out to Tristan and I. We can work with you on getting those going. And with that, I'd like to invite our new chairperson, Val, to provide us with some closing comments.
Yeah, thank you guys again so much. And again, thanks to Jen for your leadership. No, I mean, I think it's just really so exciting. And I always am energized by these meetings and the wealth of really good, big ideas that come from this group. I think that's really fantastic. And I'm excited to work with you all as we go forward to figure out how to best make those ideas into a reality that that serves our state and our Medicaid beneficiaries, our healthcare professionals, all the pieces that go towards making the state a healthier place. Also really great to hear all the thoughts about how we best integrate behavioral health going forward. I'm excited to hear what comes from the work groups in terms of goals and objectives. I think that'll be really great to get an update on next time. So again, thank you to everybody. And I think just keep bringing those big, bold, innovative ideas. I think that's what this is all about.
Thanks, everyone. Have a wonderful rest of your week. Enjoy the spring. We'll see you soon.
Thank you.
Bye.
Bye, guys.
Thank you. Bye.